Alrighty.
Alrighty. So, when in planning for today's call, Mary and Lisa and I thought it would just be a great idea. Mary mentioned we do expect many new colleagues to come and join us on our transition COP. And of course, we're delighted to welcome our new people, those who have been with us from get-go, and those who have not yet come to join us. But we really wanted to take perhaps a moment in time following what we felt was a very successful 2014 Pediatric Practice Guidelines workshop. And in particular, I'll focus in on our transition COP just a couple of weeks ago today, as a matter of fact, when we were still together in Calgary. And we thought that we would just do a little bit of background, very short, but just reminding us and also introducing maybe some new information to those who are more new to our COP, a bit about our goals and objectives, certainly flagging the achievements to date. There have been so many, and a bit of the workshop debrief, and as well as the vision forward and proposed next steps. A little bit about background and context. Again, building on or taking a step back at the same time of our workshop from just a couple of weeks ago to remind people that the goal behind CAPHC's Pediatric Practice Guidelines Collaborative is really to develop and implement as well as evaluate pediatric practice guidelines, and it's all aimed at improving and promoting quality of care, patient safety across the continuum of care. And I'm emphasizing those three very important words, describing the CAPHC community as well as describing our COP community. Again, being that continuum of care that brings together professionals, healthcare providers, families from our tertiary, quaternary environment, as well as home care, rehab, and our community organizations. Our national collaboration is based on, and I really want to describe this as CAPHC's modus operandi. It's extremely important that Lisa and Mary and I share it that way. And just to Jillian's point about the networking opportunities at the conference, that collaboration and building trust and relationships is really at the base of everything that we do, and it's terribly important to us. So that collaboration is a part of each step, steps referring to the development, implementation, and evaluation of our guidelines as we go forward. And again, collaborating through facilitation and bringing that opportunity or that platform to work together. And most of our work together, of course, we do virtually, just like we are today, using the tremendous technology that everyone does have at their fingertips. And then, of course, we're very blessed at least once a year when we can come together, because there probably is nothing better than that face-to-face. But that gives us the energy and the momentum to move forward. The last part of this slide that you're looking at, that's okay, just referring to the interprofessional component. That's another very important point to just raise and ensure everyone is familiar with, and that, CAPHC and our community of practice is population focused. But with that focus on our population, we bring together that full team, including our physicians and nurses and decision support people, researchers, our administrators, and not least our families and youth, all working together toward that common goal of developing the very best guidelines and standards of care. Priorities. So setting priorities, we have 4 communities of practice right now within our Pediatric Practice Guidelines Collaborative, and they're listed here for you at the top. transition from pediatric to adult care, pediatric pain, management of children and youth with medical complexities, as well as sepsis, specific to sepsis screening at this point in time. How did we get there? Well, back in 2011, we implemented a very comprehensive consultative process, engaging many colleagues from across that continuum of care that I spoke about a few seconds ago in setting these priorities. I think fair to say there was probably a list that was narrowed down to about 20 priorities, and these 4 rose to the top using the criteria of importance from a clinical, economical, long-term consequence for both children and families. Again, how did we get to where we are today, and where Mary is going to take the discussion in just a couple of seconds. I mentioned that, and we had an inaugural meeting in Ottawa, again, as part of our annual conference that year, where we introduced the concept of a pediatric practice guidelines collaborative, bringing to light really that there were fewer than one would expect standards for children. We recognize the challenge before us. I think it's getting better and we're addressing the challenge. We still have a ways to go. The challenge of being benchmarked against adult data, because we don't have those standards of care that are specific and address the specific needs of this population. And that's really where that inaugural discussion, if you will, in 2011 began. And from that, there was strong consensus that building a collaborative and then building communities of practice within that collaborative was the way to go. So we'll fast forward to 2012, where we expanded our national collaboration between our Pediatric Practice Guidelines Collaborative and the Pediatric Outcomes Measures Committee. And the reason we did that was to ensure measurement and evaluation became an important part and component of the equation or of our work. At our 2012 conference in Vancouver, we had a Pediatric Practice Guidelines workshop, and that's where, in fact, we identified those 4 priority areas: transition, complex care, pediatric pain, and sepsis, again, based on the criteria that I mentioned in the previous slide. And then in 2013, at CAPHC's Toronto conference, we set 4 specific agendas and work plans for each of our COPs. Tremendous amount of work has been done over the last year. In 2013 of June, I bet you it feels much longer than that, Mary, you and Kushar Maria kindly agreed to step into that co-leadership role and became our co-chairs of our transition COP. Although Veronica is not with us on the phone, I want to recognize Veronica Gazararian's interim leadership while Kush is looking after a newborn. Mary, on behalf of everyone, I want to say thank you to you for your leadership, which has been stellar, as well as so passionate. And I believe just before I talked to CAPHC's commitment to this, it's important to recognize the leadership of everyone who has participated and journeyed with us since 2011, as well as those that have come on board more recently. So what is CAPHC's commitment? And I want to reiterate, it's a very strong commitment. What I've mentioned probably a few times is I've referred to your expertise, the expertise of our practitioners and clinicians and families in the area of transition who are with us on the phone today, and those, of course, who are not. We are totally dependent on your expertise as content experts. What CAPHC, the expertise that we bring or we believe we can bring to this type of work is the facilitation. We can bring the strength of our membership, again, that network that is represented within the CAPHC community, our strategic partnerships, first of all with our member organizations, but also with other organizations, provincial, national, federal organizations like the Canadian Patient Safety Institute, the Public Health Agency of Canada, Accreditation Canada, just to mention a few. The knowledge translation, KT, is extremely important to CAPHC, and we have built and continue to build a very strong platform where we can connect the dots across the country, where we can implement and translate new knowledge, we can share priorities, we can develop homes, virtual homes for each of our communities of practice, etc. And of course, that a lot of that is done through our webinar program, as well as under our virtual leader, the Knowledge Exchange Network known as CAN. And of course, our focus in everything that CAPHC does really is on quality improvement, national standards of care across the continuum, cross-cuts everything that we do, and then of course the need to identify those key indicators to measure success, to measure whether together as a community we are making a difference. So I'm gonna stop there. I hope that's helpful to folks and perhaps brought some new knowledge to those that are newer to the COP, and maybe a bit of refresher for those who are now our veterans. And Mary, I'm happy to turn over to you at this point.
Okay, thanks, Elaine. So I'm just going to kind of go through what we've done, and just a big thank you to our group. We have a great community of practice. We've had a working group that's been meeting, you know, online, by phone. We've had the opportunity to meet a couple times now at CAPHC. At the conference this year, we actually got together 3 times. So that was excellent, because we can then, once we can connect like that, we can then talk about how can we take that home and improve our transition practices within our own practice. So that was fantastic. So just quickly, through the literature, through our conversations, every call, we've been identifying our barriers and needs for sure. Our target users for these guidelines we're developing is the clinical level. So that's the whole gamut of all clinical roles, from community, rehab, pediatrics, and adult subspecialties. So, and all of the disciplines within that. That's our target user that we're framing these guidelines for. But knowing for sure that they're being developed for our target population, which we've now defined as youth with special health care needs and their families. And our age range is, somebody can correct me, 12 to 25?
25.
25. 5?
5.
Okay. And our definition is very holistic, including, you know, holistic health, looking at their physical, cognitive, and mental health and psychosocial needs. We've developed core domains for our guidelines, which we'll look at really quickly. We've looked at literature reviews, and we're still massaging them, but we will have a very comprehensive lit review that will be attached to the guidelines. We've scaled and those articles, and we've used them to influence the guidelines themselves. Throughout all the work we've been doing as well, actually it came from a project, Geraldine and from Sick Kids and John, oh my gosh, sorry.
Greenway?
Greenway, thank you, from Airnote Kids, put together an inventory of transition tools that are on CAN. I learned this year that all of these calls are recorded, and they're all on CAN, so we have a really nice grouping of learning about all of the programs that are out there. Transition, but also content specific, like or population specific, as in Joanne shared with us her work, as well as Margaret O'Reilly from the adult perspective. And we are, one of our focuses for sure is that we're going to be focusing more on community, condition-specific groups, and or family practitioners. Another big goal that we've had is to increase our membership, and that hasn't been a problem at all. Our goal now is to help to engage them so that it has value for members. Next slide. We're trying to be very focused across the country. And I think our Saskatchewan was one of our groups that we had low numbers on, and then where else, Lisa, were we sort of missing representation?
Prince Edward Island, but now we have Saskatchewan on board, so this is great.
Yep. Welcome. Great. Definitely across disciplines, but like I said, we want to work more into the communities and the community groups that exist. And also we also are looking for more involvement from adult rehab. Our membership as well includes youth and young adults, and one of the things that came up at our workshop was how to really ensure that we have authentic youth voice. We're listening to them. Some of the youth that might be involved in our calls may have communication barriers, so we're going to be focusing on that, how we make sure that we get the youth and young adult and family voice in all that we're doing. We've also engaged in more and more people through policy that are educators, administrators, and researchers. So I said that I think our group basically in 2 years has grown from 30 to a possible 140. The 100, I guess it was about 140 people that from the Delphi said they wanted to join, and we purposely did not send them an invitation to this call because we wanted to update our current group and kind of make sure we were on the right page and direction for moving forward before we opened up the lines to a whole new group of people. And our monthly calls average around 15 to 18 people. So that's fantastic. So where are we at with our guideline development? We reviewed and used the Agree To framework. We've gone through the evidence. We looked at 20 transition guidelines. Some of them are condition specific, some of them are more generic. We've probably well over 400 published articles, graded and scaled them, and pulled together that information to help us identify core domains, which we came up with 8 by spring of 2014. We defined our target population, purpose, and target audience, which we just reviewed. Then what happened, it's kind of been a learning journey. Oh, I'm echoing now, sorry. Is we kept going back to the group and the working group and saying, well, how do we move this forward? And so they basically said, well, look, we'll break into pairs, and usually it was from across the country. So we'd have somebody from BC working with somebody from Alberta. Okay, that's not across the country, sorry. But we did mix people up. People chose the areas that they were most interested in, and then they had their own calls and really worked through the literature in pulling forward indicators for each of their domains. And then through the summer we had a couple of calls and where we pulled all of those indicators or recommendations together, and then we continued to massage it as a larger working group. Okay, sorry, we can go to the next slide.
I'm trying.
Okay, so these are our core domains, youth-focused and family-centered, right off the, that's our focus. Youth, family, and support networks. And what was interesting with the family members on the line, one of the neat things that came up, I thought, was natural networks. How do we make sure that we're supporting families in their home communities to develop natural networks that exist, because we know the dollars are going to continue to decrease and the demand will be increasing in all of our practices. Documentation and process change, education, capacity building across all stakeholders, really focusing on attachment to adult services, so our preparation, planning, transfer, and focus on attachment. Roles and care coordination, who, what, when, and how. Service planning and system change, and this is where we started conversations around influencing Accreditation Canada. and we were going to start that process in this new year, which is really exciting. And of course, evaluation strategies and outcome measures across it all. I'm wondering, okay. Sorry, I'm just trying to follow the slides. So
we were just saying that these are some of our achievements. So we've
okay, and that's right.
Yeah.
These are our achievements, but the items in red are things that we're thinking about in the new year. So we talked about how we have our monthly presentations, and that will be ongoing because people have been really positive about that. So that's the first 15 minutes of the call. We're continuing to share articles and education videos and everything through CAPHC. We did a poster for CAPHC, which we will post in Ken. And we're looking at how do we link up across provinces to do specific projects, which we'll get into in a few minutes. And also one of the other outcomes we wanted was we want to be a presenter at CAPHC. Right, Elaine?
Right.
So we were talking about doing a breakfast or a lunch session, and I would think the room would overflow.
You're right.
That is not a problem. We'll plan for that for 15.
Okay. So I think that one of the things that was talked about a lot at this conference was fake it until we make it. I love that. I think our group is great that way. Everybody comes in at a level playing field, no matter what our roles are, and we work as a group to talk about how do we move forward. So that it's a very collaborative decision-making process. Okay, I just lost my slides. Oh no. Click to save. Oh no.
And if you look along the bottom of your screen, there should be like a little flower type icon. If you click on that, it might bring them back.
Okay.
Maybe.
Okay, you might have to go, Lisa. Oh, just a minute. Sorry.
That's all right. So what we were talking about what is working. So we'll fake it till we make it and bring it.
That's pretty good.
That's what we do. And the authentic parent voice and the contribution of all of our stakeholders. And something that Mary's been able to do that has been great for her, and it would be great if we can find a strategy to enable people to do this, is seeing for your organization to see your contribution to the COP as part of your regular work. So we need a strategy to help all of your organizations to see the value in this, the value to their organization. Yeah, so that you can carve out a little bit of time out of your workday to do this. That's not sort of on top of everything else that you're doing. Well, it will be on top of everything. Who are we kidding? But just to see it recognized that way from your organization, it's been something that Mary has been able to do, and I think that in a few of the other groups, people have been able to do that as well. So it makes it easier for you and really validates all the work that we're doing.
Maybe just if I can add, it's Elaine, maybe a very quick comment to that. If there is some way that we can help you do that, please call upon us. And you know what I'm thinking about is, writing a letter or communicating with your colleague or your department head or division head, whatever the case might be, to really speak to the leadership that you're providing at a national level, but also the impact or return on that investment, if you will, at the point of service delivery, at your front line. So we can definitely, we put that out, just food for thought, but we'd be happy to help support that process.
So sort of we need to sort of think about a strategy around that for everybody. And this is a picture of us all at the workshop, working hard, smiling, happy to be there on day 4 or 5.
Drawing on the walls.
Writing on the walls.
Yeah. I got my slides back, so that's great.
Okay, there we go.
Okay. So our goals were to look at, our successes to date in developing the guidelines and doing the Delphi. Our short-term, medium, and long-term goals, we decided I think we're going to be around now till 2019, and then look at defining some subgroups. And again, I think this comes back full circle to creating subgroups that impact your current practice or work that are useful and have value add for you. Okay, so these are just the key points that the working group fleshed out. We're going to talk about research and data in developing the,
Sorry.
Okay. That's okay. Engagement and how we're engaging people and how we can do a better job of that. Clinical practice guideline development, evaluation, education policy, and marketing and promotion. So then we ended up with all of those posters that you saw behind the lovely group. So this is kind of our overview of where we're at with our guidelines again. I think probably one of the key messages is that we want to make sure we always have an authentic voice of youth and families to inform the guideline. We had discussion back and forth and really came away with our focus is clinical, at the clinical level in developing these guidelines, but as they're developed, we will translate them with youth and families to make sure they're in youth and family friendly language and they're presented to them in a way that they understand them. So it's not that we're developing them at all without the youth and families at the table. They very much are, but the language of the guidelines that went out in the Delphi are at a clinical level. And also our Delphi process, we had also talked about with the group around should this be done as a research project, which would have made, and Gail's on the call, which is great. We did some background look at that. It would mean probably a year's worth of trying to get ethics approval across organizations. And what was our desired outcome? Our desired outcome is that we are published, that we publish and share them. So with working with CAPHC, we probably have a better chance of getting them published through quality improvement journals, and we can speak to the Delphi as our process for developing them. Gail, did you want to say anything about that?
Well, just my comments that I sent earlier this morning that I think getting this knowledge disseminated is so critical. But then we need to then go into the phase of implementation of getting the guidelines used, and having that information really change outcomes in the positive direction. And I think that's where we can kind of land the research piece on the implementation side.
Great, thank you. And yeah, in small bits. Then the other piece we talked about was partnering with other research or data partners that are already looking at data, that looking and measuring outcomes, that we wouldn't go and create our own, that we would work with them and give them hopefully a passion for transition and help us to be able to look at our increase in numbers probably across the country and look at our outcomes and how many kids are accessing adult care. The other thing, the point is that all of our work is in progress and it's not for distribution at this time. So our literature review, our responses from our Delphi, we've been given the responsibilities of people's consent, but we won't be providing any of that information. We will be aggregating it towards the work that we end up with. But so that just basically, respectfully, everybody who joins our community of practice, you're welcome to join the working group, but that the information in its development stages is not for distribution. So our Delphi, we had, as I said, a working group. By the early fall, we had developed these domains, 8 domains, with each about 4 recommendations per domain. And then we were sort of like, well, what's our next step? And our next step was go back to our community of practice or the community at large and say, how are we doing? And we knew that they were really wordy. We knew that they were repetitive. But I think that was part of the process. Some people within their domain said, no, I want it repeated in my domain. It's that important. So that's fine. So we decided as a group we would massage them as much as we could, and then we would send it out. We had 600 people when basically everyone from the community of practice was invited, plus they were also invited to submit names to Lisa, and they did, and we ended up with about 600 names to the list, and by the last day, let's see, by the last day was Friday, and 305 submissions had come back. On the Tuesday, wasn't this right, Lisa? We were at 1 something, or no, yeah, 1 something, 180.
Yeah.
So within 2 days, 100 and whatever came through the door.
Yeah.
So that's phenomenal, 50% response. So now we'll work as a group, a working group, and anyone's welcome to join to take a look at all those comments. Lisa said to me, oh, well, we've got some comments. And I said, okay, well, we can do that as a working group at the conference. But we got 40 comments per indicator or recommendation. So of those 40, 10 might be, I totally support this, but some of them may be wordsmithing, and then other people have shared a story. So I think what's really important to note is that people took the time to write out a comment per recommendation. So it's fantastic. So we need to now, we'll meet again a number of times, massage that work, and then our working group wants to send out a check-in to the 305 people who responded. So to be respectful to their time and effort, we will send them out, and if you were part of that, that's great. Here's how we've refined them. Did we meet all of your suggestions, and get that feedback? Once we've had all of those revisions put in, we will do out a second Delphi in February. Any comments, thoughts, people that were involved? Anybody want to comment on that?
It's John from Aronoke. I have a question. Do you have it broken down by province, the feedback?
Not right away. Not right now. I don't. We can do that for sure. Just the Delphi closed on the 17th. And I went to a conference the next day. I went to a conference the next day. So it's a pretty high level how I have it sorted right now.
But Lisa did do up some slides for us for the working group, John, and she did a pie graph of response. But there's bias in there because I had from BC, there's about a 60% response rate from BC, but that's because that's part of my work, and I had a database that I sent out 250 names.
Right.
So that's probably a weakness that we might have to recorrect or adjust for.
I also thought there may be some common themes coming out of different provinces, that's all.
Well, that's good to look for. That's great. We will do that in our working group.
I would be surprised if that wasn't the case.
Yeah.
Mm-hmm. I don't know. Yeah. I think we talked to some of the issues around engagement, so moving forward. We talked about we really want to increase our adult community providers, our family physicians, making sure we have youth, young adult, and family voice well heard. We talked about having champions or leads for the subgroups, so that if somebody wanted to come forward, for example, and be the lead for engagement, that would be fantastic. What else here? Authentic voice and value add strategies we talked to, and how you could build it into your role. And then I think the project work too was streamline and share transition processes across the province. You know, when you sit down with each other, our colleagues across the country, we're all doing similar things. And how do we share that and not keep recreating the wheel? Okay, so I think again, I talked to about making sure we capture youth voice, doing the knowledge translation piece around making sure the guidelines are youth, family, community friendly. We talked about, once we have the guidelines done, developing youth and family focus groups or workshops to make sure that we do that work. Lessons learned across populations. I'm not too sure.
That's right. So just
okay.
Evaluation.
Clinical evaluation. So how do we test our guideline? And this, I like that the year is 2017. But we need to get to that stage, and this really needs leadership of people with evaluation expertise. And this was just a list of different ideas from the working group on how we move forward. Felix came up with the one-page core messaging so that we do some promotion for sure and just have a clear message of what our guidelines are from CAPHC for our country. And then these were some of the other ways to do evaluations, process evaluation, and look at outcomes. Education, definitely. So once we complete our guidelines, how do we take them into workshops and webinars? How do we access other groups that exist and partner with them? Again, we looked at the data numbers. How do we partner even higher levels with Accreditation Canada or the ministry? And ways to kind of keep developing a repository of transition tools and catalog it so that people don't need to recreate things. We already have a lot of those pieces. I think the other thing that, let's see what the next slide says. Policy. So there's the accreditation piece, I think, and the engagement of other partners. But I think the other piece that came up, we talked a lot about too, was, you know, the resource, the funds are decreasing, our patient populations and complexities are increasing. How do we make sure that those populations that need it the most get the transition support that they need? And that was a common theme across our conversations. Really, and this would be possibly where we start to connect more with the complex care group that's developing clinical practice guidelines. And this, our whole marketing and promotion. There's lots of avenues. So if you could take a look at these headings, and if you're interested, we're definitely looking at leadership, if anyone wants to come forward and lead any of these project areas.
And that's just me.
Okay. Parking lot. Okay. So before I start all that, does anybody want to, that was at the working group sessions or has been on the calls, want to make any comments about moving forward?
Have we overwhelmed you with all of this information and all of our brainstorming?
This is Heather from the Stollery. As some of you know, we've been reaching out to you to help us gather information that you've been doing and looking at what the Stollery can do in terms of adopting a framework and then adapting that to specific needs to the different clinics. And I just think all this groundwork that has been done through this community of practice has been huge. So I just hope that we can find an effective way to be able to share this material with all the stakeholders here at the Stollery to help us move forward. But I see lots of possibility with it, so I just want to thank you for all this work.
Oh, great.
Fantastic.
That's great. That's great because, you know, like we keep saying in all of our working sessions and roundtables that we're all doing such similar work. And how do we then maybe either partner together and test it and see what the best way to do it is. Also, if you know, this work's already been done and you can just duplicate it, then someone else can take a new area that really hasn't been measured or looked at, which is attachment. You know, if 98% or 99% of our kids are now becoming adults, what does that attachment piece look like in adult care? And how do we take them in? Which is a huge piece of work that's just beginning. Oh, I just talked to that. The second point here was attachment. How do we start to look at what that actually means and looks like? Looking at our new membership, knowledge, yeah, I think we've talked about all of these pieces.
Mm-hmm.
Does anybody know, we just threw them at you, but other than education, clinical guidelines, research, testing, and evaluation, yeah, thanks. Are there any other areas that we missed? Policy being the accreditation piece, that's huge.
Actually, we've talked, Mira, I'm just Lisa again. We've talked about Accreditation Canada, but it does occur to me that not all organizations are accredited by Accreditation Canada. There's other accrediting bodies, so we have to also consider other accrediting bodies as well.
That's
a great point.
It's an excellent point, and we can. Now, CAPHC's primary partnership right now has been with Accreditation Canada, absolutely, but that doesn't preclude working with others, and that's where we would look to our community to make some recommendations as who those others should be.
Yeah, and that came up with a working group that a number of people were not accredited, like different accreditations. So I think we use Accreditation Global, and then we look at who all the groups that we'd have to connect with are.
Yeah.
It's Gail here. We just had a closing session this morning at this conference on knowledge translation about influencing policy. Mm-hmm. And they talked about we really have to have a voice, so I think even at a provincial level or at a local institution level, we have to really make sure that we keep talking about fostering the culture of evidence-based decision-making. So we have our local organizations and provincially, and then nationally, everybody's on board.
Thank you.